Hi, my name is Allison Dorogi. I will be a freshman at Duke University this coming fall. I spent the summer in cardiothoracic surgery with my mentor, Dr. Smadira, as a member in the Science Internship program. My project for the summer is titled Heart Weight and Outcomes After Heart Transplant, a Descriptive Study. So first, some background. In the past, increased donor heart weight has been associated with poor surgical outcomes and a higher risk of postoperative complication and infection. However, previous studies concerning the relative risk of cachectic, those patients that are very thin, and obese transplant candidates, we've decided to investigate what impact the donor heart weight might have upon the recipient. So our objective is to investigate the association between the donor heart weight and outcomes on the recipient after transplant. So we've decided to group that into three main categories. First being the description of the donor heart weight and associations with different recipient characteristics. Secondly, the donor heart weight and its association with the length of stay after heart transplant. And last, the donor heart weight and its relationship with all-cause mortality after heart transplant. So a little information about the demographics. We had 1,348 patients in our study, which all patients had received a heart transplant between 1984 and July 2010. The mean age of the patients was about 53. It ranged from 18 to 75, so a standard deviation of about 12 years, and then 78% of the patients that we studied were men. All patients were systematically followed. The median follow-up time for the whole group was 6 years, and 2 years followed up was 25%, and the 75th percentile was 11 years. 25% of the survivors were followed for more than 12 years, and 10% of the survivors were followed for more than 15 years. So here's a chart just listing some more demographic information. As you can see, the mean age was about 53. BMI rested around 26 because most patients, when considered for transplant, have to be in the normal BMI range in order to be eligible. Most patients were about 35 years old, give or take about 14 years, and the ratio between recipient and donor was relatively equal, from 1.1 to about 1.4. So our results and analysis. This first graph shows the average donor heart weight. So we graphed all of the heart weights as we were given them through our patient data. Every single donor heart is weighed right before it is transplanted into the recipient. And so from this we can see that the average donor heart in grams is about 350. This graph shows the donor heart weight versus the date of transplant. We're missing data for 2001 because they did not weigh hearts at that time. But as you can see, it started that we were initially given hearts with less weight, around 350. Then it slightly rose early 2000s, and since recently has actually gone down a little bit, which is nice to see. The next shows its relationship with recipient age. And earlier, they used to give hearts to patients that were younger. It actually is influenced by the way people were listed. In earlier years, they would give hearts to patients that were relatively sick but not dying, and now it's switched to patients that are getting mechanical circulatory support and other different devices put in, so they'll be a lot older. This graph shows the relationship between the donor weight and the recipient weight. It used to be that we were giving the heavier hearts to most patients, but recently, even when the recipient is much heavier than the donor, we're still giving lighter hearts because many doctors and surgeons were fearing the adverse outcomes that might happen if we were giving them a heavier heart. Next is the length of stay. The median length of stay is about 15 days. On average, the length of stay would decrease by 1 week with the increase in donor heart weight from about 200 to 400 grams. And then the length of stay would increase again with the increase in donor heart weight. So you can see that in this next graph where the length of stay is actually the longest for those patients receiving the lightest hearts. It'll go down for the average heart, and then it actually spikes back up a little bit for the very heavy hearts. But it's very interesting to note that the highest wait time in the hospital will be for those receiving the very light hearts, which are generally preferred. Then its relationship with survival rate. The overall survival estimates are about 96% at 1 month, 90 at 1 year, 84 at 3 years, 78 at 5 years, 69 at 7 years, 57 at 10, and 34 at 15 years. So it's always decreasing. This graph shows the three different categories that we have, the blue being the lightest category, the golden color being the average heart rate, and red being those patients receiving a very heavy heart. For the most part, you can tell that the heart rate does not have an impact upon survival rate, although in the very beginning, when we were just first beginning to analyze our research, we noticed that around between 0 to 3, there's a slight decrement in the blue category with the patients that are receiving the lightest hearts. And although it does not quite reach statistical significance, this could be something that would cause further study because, again, like we said, many doctors and surgeons prefer those lighter hearts, but if it might impact their survival within the first year, that might be something that we want to change. So in summary, the recipient age and donor heart rate have both increased over time, and there appears to be a nonlinear association between donor heart rate and length of stay, with patients receiving the lightest and heaviest hearts having the longest hospital stay. And then although donor heart rate does not appear to be associated with survival, there is a slight decrement, that blue line at the beginning, in early survival in the very lowest weight group. So some of the implications are that the concerns about the heavier hearts impacting survival are not warranted in any way, and that the larger hearts can actually be safely used. This can actually help reduce the transplant waiting times because doctors and surgeons will be able to use those hearts that they had previously considered too heavy, and they'll be able to shorten the waitlist time. However, hearts at either weight extreme, so those cachectic patients and those obese patients, may be more sensitive to ischemic arrest, and they could have delayed functional recovery, and which could lead to longer hospital stays. But we would much rather have them stay in the hospital a couple more days than lose potential candidates for transplant and potential organs for transplant. So finally, I'd like to thank my mentor, Dr. Smadira, as well as Kathy Herscher, who I was working with throughout this summer. And then I'd also like to thank the Office of Civic Education Initiatives, especially Ms. Strickland and Ms. Starling. Thank you.